Hello everyone. So the topic we will be discussing today is leukemias. We will discuss the AML and CML. So what is leukemia? It is a malignant disorder associated with increased numbness of the primitive white cells, that is blast cells, in the bone marrow. We are having a scenario that there is a 30 years old man which presents with the history of fever, sore throat and bone pain. Recently episodes and gum bleeds. On examination looks pale, toxic and febrile, has purpuric spots on the skin and has splenomegaly. The temperature is 102 degrees Fahrenheit, BP 115 by 75, HB 8.5, and TLC is 80,000. Neutrophils 25%, blast 50%, platelets, and the platelet count is 30,000. Blood urea, serum creatinine, liver function tests are normal, and the MP spares are reported negative. Another scenario is that there is a 25-year-old patient increasing fatigue, bone pain, sore throat, fever on and off, and history of epistaxis, gum bleed. On examination, he looks pale, toxic, and febrile. Generalized purpuric spots on the skin and has splenomegaly. Temperature is 101 degree Fahrenheit and BP 110 by 75. Lab investigations shows HB 8 gram and TLC 80,000 with 50% blast cells, and blood urea and serum creatinine are normal. So the MP smears are negative. What is the diagnosis, the investigations, and the management? We are having the definition of AML, that it is acute myelogenous or myeloid leukemia are present about 8 times more common in adults than ALL. ALL is acute lymphocytic leukemia, and ALL is common amongst young children and uncontrolled fashion and replace normal bone element. The above scenario is most probably AML, as all the three cell lines are abnormal, that is splenomegaly, bleeding gums, and blast cells. So these points support my diagnosis. The investigation options for AML are: best initial test is CBC, smear showing blast cells with pancytopenia. Then most accurate bone marrow biopsy with the flow cytometry to classify leukemia type, and hypercellular more than 20% blast cells. Serum uric acid is increased, serum calcium is increased, blood culture is done, X-ray chest is done for mediastinal mass. CSF findings shows blast cells in CSF is about 5%. LDH is increased, and bone marrow biopsy is done, which shows 20 myeloblast in the bone marrow granular cytoplasm of myeloblast, and myeloblasts are myeloperoxidase positive and Sudan black positive, or rods, that is eosinophilic granules in cytoplasm of the myeloblasts. The clinical features are anemia, infection, skin fatigue, bruises, gum bleeding and epistaxis, bone pain, splenomegaly, and lymphadenopathy. The management options for AML are supportive care, that is for anemia, blood transfusion is done when HB is greater than 10 gram per DL. For bleeding non-infected patient, give platelets count less than 10,000, and infected patient give platelets when count is less than 20,000. For infections, antibiotic is given, that is aminoglycosides and broad-spectrum penicillin. For fungal infection and local infections, fluconazole is given, and for systemic infection, intravenous amphotericin is given. The specific care for AML is re-emission induction, that is this phase destroys bulk of the tumor by combination of chemotherapy, that is daunorubicin intravenous and cytarabine intravenous. Then re-emission of the consolidation, that is cytarabine intravenous, attacks residual disease. One remission has been achieved. Then the re-emission maintenance, this phase is not required in AML, it is given in ALL. The prognosis is poor with following: increasing age, male sex, high leukocytes level at diagnosis, and CNS involvement. So we have discussed the first topic, that is AML. We discussed the scenario, then the definition, the investigation options, which are best initial test is CBC, and the most accurate is bone marrow biopsy. Serum uric acid, serum calcium, blood culture, X-ray chest, CSF findings, LDH, and bone marrow biopsy is done. Then the clinical features are discussed. Then the management options, which are supportive, that is anemia, bleeding, infections, and fungal infections. Then specific care, which is remission induction, remission consolidation, remission maintenance, and prognosis. Now coming towards the next, that is CML. We are having a scenario that there is a 60-year-old man presented with pain and dragging sensation in the left hypochondrium. On examination, he is pale and large from spleen, palpable up to umbilicus with no lymphadenopathy. Investigation shows HB 10 gram, TLC 1,50,000 with no blast, LFT is normal, and MP smear is negative. Another scenario is that there is a 65-year-old male, history of aches and pains, weight loss, sweating, pain in the left hypochondrium. On examination, massive splenomegaly up to the umbilicus is present, low lymphadenopathy, neutrophils 35%, and limbs are 10%, and LFTs are normal. Then another scenario, we have 55-year-old male, low-grade fever, night sweats, feeling of illness on left upper abdomen, splenomegaly. FBC shows SB 9.6 gram per dl, TLC 1 lakh 60,000. So what is the diagnosis, investigation, the complications, and enumerate 3 causes. The definition of CML is that it is a myeloproliferative neoplasm with clonal overproduction of hematopoietic myeloid stem cells that can differentiate. The clinical features are increased total leukocyte count that is greater than 1,50,000, low lymphadenopathy, massive splenomegaly, weight loss, age, all favor CML. So the investigation options are CBC, that is WBC is raised and platelets are normal or elevated. Leukocytosis is there, anemia, thrombocytosis, and basophilia is there. Blood LDH and uric acid level are elevated. Then bone marrow biopsy is done, which is hypercellular with increased myeloid to erythroid ratio. Then Philadelphia chromosomes done, RNA analysis, that is BCR to ABL gene product. Then the neutrophil alkaline phosphatases are done, which are low, and mast cells are osteoclast. Serum vitamin B12 is done, which is increased due to increased secretion of transcobalamin 3. Serum uric acid is high, and Philadelphia chromosome may be present. The management options are general, which are hyperviscosity with leukophoresis in conjunction with myelosuppressive therapy. Then the specific managements are tyrosine kinase inhibitors are used, which are imatinib drug of choice, and failed to imatinib second generation. Then second generation drugs are used, which are dasatinib and nilotinib. The bone marrow transplant is done when allogenic bone marrow transplantation, especially in younger patients. Nowadays not used because of response to imatinib. Hydroxyurea is done. Patient can't tolerate imatinib, should be given hydroxyurea or interferon. The causes of massive splenomegaly are CML, myelofibrosis, lymphoma, Kela-Azar disease, leishmaniasis, malaria, beta thalassemia major, and AIDS with myobacterium. So we have discussed the topic CML. Then we discussed the scenario and the definition, then the clinical features, then the investigations, which are CBC, bone marrow, neutrophil alkaline phosphatase, and serum vitamin B12, and serum uric acid, and Philadelphia chromosome. Then we discussed the management options, which are general and specific. For specific, we do tyrosine kinase inhibitors, bone marrow transplant, hydroxyurea, and causes of mesospleenomegaly. Coming towards the next topic, that is polycythemia rubra vera, we have a scenario that there is a 40-year-old man complains of headache, dizziness, spell pain, epigastrium, and itching after a hot bath, and on examination he is plethoric and spleen is palpable. HB is 18 and total leukocyte count is 1 lakh 60. So the headache, dizziness, occasional blurring vision, and severe itching after a hot bath. On examination, the plethoric face and palpable spleen is present. The definition of polycythemia rubra vera is that it refers to increase in RBC's mass with or without increase in granulocytes and platelets in absence of physiological stimulus. The clinical features are headache, dizziness, tinnitus, blurred vision, increased risk of MI and stroke and DVT, but carry syndrome, thrombosis of the hepatic vein, transient blindness, ocular migraine, bleeding, pruritus after hot bath, and peptic ulcer disease, gout, splenomegaly, plethora, hypertension, and engorged retinal veins, and polycythemia vera. The investigation options for polycythemia rubra vera are CBC, that is hematocrit is greater than 54%. HB increased, WBC is increased, and platelets is increased. Red cell mass is elevated. Bone marrow shows megakaryocytic hyperplasia, absence of Philadelphia chromosomes, and lack of collagen fibrosis, and normal iron storage. The peripheral smell shows large hypogranular platelets and mild leukocytosis. ABGs is done for hypoxia. Serum erythropoietin is done, which is low, increases in physiological polycythemia. The treatment options are aspirin, which low dose decrease risk of the thrombosis, and venesection 400 to 500 ml of blood is removed, and venesection is repeated every 5 to 7 days until hematocrit is reduced to below 45%. Bone marrow suppression is done, that is hydroxyurea or hydroxycarbamide or infection alpha may reduce risk of the vascular occlusion. The prognosis is median survival after diagnosis is in treated patient exceeds 10 years or sometimes more than 20 years. The complications are thrombosis, peptic ulcer disease, gout, and GI bleeding. So we have discussed the polycythemia rubra vera, the scenario for it, and the definition, the clinical features. Then the investigation options, which are CBC, renal cell mass, elevated bone marrow, peripheral smear, ABGs, and serum erythropoietin. Then the treatment options, which are aspirin and venesection and bone marrow suppression. Then the prognosis and then the complications. Now coming towards the next topic, that is myelofibrosis. We are having a scenario that there is a 65-year-old female presents with fatigue and heavy sensation along left side of the abdomen. On examination, she is anemic with massive splenomegaly. Laboratory investigation shows HB 9 gram per dl, WBC 2.1 into 10 raised to power 9 millimole per liter, platelets 90 into 10 raised to power 9 millimole per liter, blood film shows teardrop cells, diagnosis, investigation, treatment, and complications. So the definition of myelofibrosis is that it is myeloproliferative disorder characterized by fibrosis of the bone marrow, splenomegaly, and leukoerythroblastic peripheral blood picture with teardrop poikilocytosis. Myelofibrosis, bone marrow fibrosis, and extramedullary hematopoiesis, that is blood formation. The clinical features are ineffective erythropoiesis, that is anemia, massive splenomegaly, hepatomegaly, night sweats, fever, weight loss, splenic infarcts with left-sided pleural effusion. The investigation options are blood CP, which are blood CP for anemia, leukoerythroblastic picture, that is a combination of immature RBCs and WBCs, and teardrop shaped red cells and poikilocytosis. Then WBC count is done, which is initially high, later leukopenia may occur. Platelet count is done, which is initially high, and later thrombocytopenia occur. Then bone marrow is done. Very difficult to aspirate, dry tape, and trephine biopsy shows increased fibrous tissues. Peripheral smear is done for large abnormal platelets. The treatment options are supportive treatment, which are transfusions, folic acid, hydroxyurea given to reduce spleen size and to reduce very high WBC count, and splenectomy may be required in patients with recurrent painful splenic infections, and bone marrow transplant should be considered in young patient. The complications are portal hypertension, intestinal obstruction, hepatic failure, bone marrow failure with pancytopenia, and acute leukemia. So we have discussed the case of myelofibrosis, its scenario, then the definition, the clinical features, and what the investigations are done. That is blood CP, WBC count, platelet count, bone marrow biopsy, and peripheral smear is done. The treatment options are supportive, which are transfusions, folic acid, hydroxyurea, splenectomy, and bone marrow transplant. And then we discuss the complications. Now coming towards Hodgkin lymphoma. Okay, we are having a scenario that there is a 25-year-old female came to medical OPD with the complaints of low-grade fever and painless swelling in neck and weight loss from last 1 month. On examination, she is vested having enlarged form rubbery left cervical lymphadenopathy. She is having moderate splenomegaly, and ultrasound confirms splenomegaly and revealed para-aortic lymphadenopathy. Another scenario is that there is a 28-year-old man, episodic fever, sweating, weight loss for last 1 year, discrete rubbery cervical lymphadenopathy, and form splenomegaly. HB is 9.8 gram per liter. Platelets and TLC counts normal. Then eosinophil count is 20%. So what is the diagnosis, investigation, and the management? The clinical features for Hodgkin lymphoma are lymph node enlargement, lymph nodes painless, hepatosplenomegaly is there, fever and evening night sweats, and weight loss greater than 10% of the body weight is present. Lymphoma is a malignant tumor of lymphoid tissues and characterized by abnormal proliferation of the B or T cells in the lymphoid tissue. The Hodgkin lymphoma is characterized by aggressive enlargement of the lymph nodes due to hyperplasia and infiltration with histiocytes and lymphocytes, and pressure of the characteristic Reed-Sternberg cells is present. The causes of Hodgkin lymphoma are infectious, which is pyogenic toxoplasmosis and Kidd-Stage disease. There are chronic causes, which are TB, syphilis, and HIV, and malignancy causes, which are non-Hodgkin lymphoma, acute lymphocytes, leukemia, metastatic spread, breast and stomach, etc. The investigation options for Hodgkin lymphoma are CBC, which is normal mesh or normocytic anemia, normochromic lymphopenia. Then ESR, which is raised, serum LDH is checked, which is raised level associated with poor prognosis, raised LDH and adverse prognosis. Then chest X-ray is done for mediastinal widening and lungs involvement. CT scan is done for chest, abdomen, and pelvis. For staging and positron emission tomography is done for staging and assessing response to therapy. Excisional lymph node biopsy is done. Ultrasound of lymph node and singular method is done, and LFTs may be normal. The treatment options are radiotherapy, chemotherapy, and for stage 1 and 4 chemotherapy regimen is given, that is chlorambucil, vinblastine, procarbazine, and prednisolone. Then 80% patients respond to about regimen when repeated every 3 to 4 weeks for total 6 to 8 cycles, and risk of infertility in male is very high. The prognosis is 190% with stage 1A are cured by radiotherapy alone. The patient with stage 2A have reduced cure rate from radiotherapy. Approximately 70% treated with chemotherapy are cured. 15% who failed to initial chemo have poor prognosis. Then the other topic is multiple myeloma. We are having a scenario that there is a 70 years old female having severe joint pain and lower back. On examination, she is standard or lumbar spine. X-ray hip joint shows fracture of the neck of female and HB is 6. Total leukocyte count is 7200 and platelets are normal. ESR is 110. So the definition of multiple myeloma is that it is a malignant disorder of the plasma cells, or multiple myeloma is a clonal proliferation of neoplastic plasma cells in the bone marrow. The clinical features are bone tumors and vertebral column common. Then the causes are hemolytic causes, renal causes, amyloidosis, and infectious. The differential diagnoses are plasma cell leukemia, plasmacytoma, osteoporosis, osteomalacia, scurvy, and osteogenesis imperfecta. Investigation options are diagnosis of myeloma requires detection of at least 2 of the following abnormalities, that is, the presence of paraprotein on serum protein, electrophoresis, and bone marrow biopsy is done which increased plasma cells greater than 10% on the bone marrow biopsy. Bone marrow biopsy shows infiltration of the marrow with malignant plasma cells. X-ray is done which shows osteolytic lesions, axial skeleton, skull, spine, and long bones. Increased ESR and CRP is there. Elevated blood urea, nitrogen, and creatinine. Elevated total protein with normal albumin. The treatment is supportive and specific. In supportive, high fluid intake to treat renal failure and hyperkalemia, analgesics for bone pain, allopurinol for uric and nephropathy, uric acid nephropathy, bisphosphonates for hyperglycemia, and plasmapheresis for hyperviscosity. The specific treatment options are chemotherapy, that is vincristine, erythromycin, and dexamethasone, radiotherapy, and transplantation, that is stem cell transplants. The other options are bisphosphonates therapy, thalidomide with dexamethasone, and the complications are spinal cord complications, cardiac failure, fractures, neuropathies, bleeding, death, and renal failure. So in this last video we have discussed the following 3 topics, that is CML, polycythemia rubra vera, CML, polycythemia rubra vera, myelofibrosis, Hodgkin lymphoma, and multiple myeloma. The rest of the topics are discussed in the hematology section of video part 1 and part 2. So here we have covered the topic hematology, and in the next section we will discuss the infectious diseases. Thanks for watching.